congenital and developmental anomalies of kidney. How does a kidney develop? The normal renal development is dependent upon the interaction between the ureteric bud and metanephric mesenchyme, which induces organogenesis, resulting in the formation of nephrons and collecting system of each kidney. The neonatal kidney achieves concentrating ability equivalent to adult by the age of 1 year. About 10% of people are born with significant malformation of the urinary system. Now, what are the common congenital renal anomalies? First, it can be renal agenesis. Renal agenesis is congenital absence of kidney. Unilateral agenesis is much common than bilateral agenesis because bilateral agenesis is incompatible with life. When the kidney is solitary, that is single, it enlarges as a result of compensatory hypertrophy. Some patients develop progressive glomerular sclerosis as a result of adaptive changes, leading eventually to chronic renal disease. The second congenital renal anomaly can be renal hypoplasia. Renal hypoplasia means failure of kidney to develop normal size. That is, congenitally a small kidney with reduced number of nephrons but normal architecture. As in case of agenesis, unilateral hypoplasia is commoner than bilateral hypoplasia. Bilateral hypoplasia usually presents with signs and symptoms of chronic renal failure. The third congenital renal anomaly can be ectopic kidney. Ectopic kidney means kidney is not located in its usual position. Because of the abnormal position, tortuosity of the ureter may cause obstruction to urine flow, which predisposes to bacterial infections. Now, the fourth congenital renal anomaly can be horseshoe kidney. Horseshoe kidney is a developmental anomaly where there is a failure of complete ascent of kidney with the fusion of lower or upper poles. The fusion of lower pole is more common than fusion of upper pole. Here, the two kidneys join together. More commonly at the bottom to form a U-like horseshoe. So the two kidneys join together more commonly at the lower pole to form U-like horseshoe. That's why this is known as horseshoe kidney. The fifth anomaly is cystic disease of kidney. It includes various conditions related to the formation of cysts in one or both kidneys. It may be congenital or acquired, non-neoplastic or neoplastic. The clinical presentation of cystic kidney may include abdominal mass, infection, respiratory distress, hemorrhage, and neoplastic transformation. There are Various types of cystic diseases of kidney. First, multicystic renal dysplasia. Multicystic renal dysplasia is a sporadic disorder that can be unilateral, most commonly, or bilateral. Renal dysplasia is a common cause of an abdominal mass mimicking neoplasia in children less than 1 year of age. There is association with congenital urinary tract obstruction in about 50% of cases. Grossly, in multicystic renal dysplasia, the kidney is enlarged and cystic. The kidney or its affected part is replaced by disorderly mass of multiple cysts resembling a bunch of grapes. Microscopically, there is presence of undifferentiated mesenchyme, that is connective tissue, that contains smooth muscle, cartilage, and immature collecting duct. The picture shows gross appearance of dysplastic kidney. Here the kidney is replaced by disorderly mass of multiple cysts resembling a bunch of grapes. So the entire kidney over here is replaced by disorderly mass of multiple cysts. These are multiple cysts, and it resembles a bunch of grapes. Now the second type of cystic disease of kidney is polycystic kidney disease. The polycystic kidney disease is a disorder in which major portion of the renal parenchyma is converted into cyst of varying size. The disease occurs in two forms. First is adult polycystic kidney disease, also called autosomal dominant polycystic kidney disease, because the pattern of inheritance is autosomal dominant. Second is infantile polycystic kidney disease, also called autosomal recessive polycystic kidney disease, because the pattern of inheritance is autosomal recessive. Adult polycystic kidney disease, that is autosomal dominant polycystic kidney disease. It occurs due to mutation in PKD1 gene, which encodes polycystin 1 protein located on chromosome 16 in over 85% of cases, while the remaining 15% of cases have mutation in PKD2 gene, which encodes polycystin 2 protein located on chromosome 4. Though the genetic defect is present since birth, yet it manifests in third to fifth decades of life. The adult polycystic kidney disease presents clinically as hematuria, renal colic, hypertension, urinary tract infection, and progressive chronic renal failure with proteinuria and polyuria. Morphological feature: grossly, the kidneys are bilaterally enlarged up to 3 to 4 kg and lobulated due to underlying cyst. The cut surface shows cysts throughout the renal parenchyma. These cysts are filled with a straw-colored fluid. Histologically, the cysts arise from the tubules throughout the nephrons and have variable lining epithelium. The cysts are spherical in shape. As these cysts enlarge, they may encroach on the calyces and pelvis to produce pressure defect. In the end stage, the kidney is hugely enlarged and shows severe interstitial fibrosis, chronic inflammation, and thickened vessels. Extrarenal congenital anomalies associated with adult polycystic kidney disease. About 40% of patients with adult polycystic kidney disease have cyst in the liver. Cyst may also be present in spleen, pancreas, and lungs. There may be presence of intracranial Berry aneurysm in the circle of Willis. Patients with adult polycystic kidney disease may have cardiac anomaly in the form of mitral valve prolapse. Here the picture shows gross appearance of adult polycystic kidney disease. The kidneys are bilaterally enlarged. Both the kidneys are enlarged, heavy, and have lobulated appearance. These are lobulated appearance on external surface due to underlying cyst. The microscopic appearance of adult polycystic kidney disease shows the renal parenchyma is replaced by cyst. So here the entire renal parenchyma is replaced by the cyst. These are the cysts. And these cysts are lined by flattened epithelium. So this is the lining of this cyst. This is the lining, and these are lined by flattened epithelium. The second type of polycystic kidney disease is infantile polycystic kidney disease, also known as autosomal recessive polycystic kidney disease. It occurs due to mutation in polycystic kidney and hepatic disease 1 gene, that is PKSD1 gene, which is present on chromosome 6. It is less common compared to adult polycystic kidney disease and is always bilateral. Serious manifestations are present at birth and result in death from renal failure in early childhood. Whereas in adult polycystic kidney disease, the clinical manifestations are present at third to fifth decade of life. Morphological features. Grossly, in infantile polycystic kidney disease, the kidneys are bilaterally enlarged with a smooth external surface. So the external surface is smooth. Unlike adult polycystic kidney disease, where the external surface is lobulated, the cut surface shows cylindrical cyst radiating from medulla up to the cortex, giving the kidney a sponge-like appearance. Whereas In adult polycystic kidney disease, the cysts are spherical in shape, distributed throughout the cortex and medulla. Histologically, the collecting tubules show cylindrical or scapular dilatation and are lined by cuboidal or low columnar epithelium. Clinical feature of infantile polycystic kidney disease. The renal failure occur early in life, maybe in perinatal, neonatal or infantile or juvenile age. Patients who survive infancy develop congenital hepatic fibrosis. Which leads to portal hypertension and splenomegaly. So, in infantile polycystic kidney disease, there is extrarenal involvement in the form of hepatic fibrosis, while in adult polycystic kidney disease, there is extrarenal involvement in the form of hepatic cyst, which involves 40% of the patient. The cyst may also be present in a spleen, pancreas or lungs, intracranial berry aneurysm, and cardiac anomalies in the form of mitral valve prolapse. The picture shows infantile polycystic kidney disease, where the kidney is enlarged. The kidney is enlarged but has a smooth external surface. But the external surface is smooth. Unlike adult polycystic kidney disease, where the external surface has lobulated appearance. In infantile polycystic kidney disease, here the cysts are cylindrical in shape. These cysts are cylindrical, you can see here. These are cylindrical in shape. These are the cysts, and these are cylindrical. Radiating from medulla to outer cortex. So these are radiating from medulla to the cortex. Unlike adult polycystic kidney disease, in adult polycystic kidney disease, the cysts are spherical and distributed throughout the cortex and medulla. Now to summarize the difference between adult polycystic kidney disease and infantile polycystic kidney disease. This is important because sometimes this is asked in examination. First, adult polycystic kidney disease is an autosomal recessive, whereas infantile polycystic kidney disease is an autosomal recessive condition. Autosomal dominant polycystic kidney disease, the clinical manifestations are present at third to fifth decade of life, whereas in infantile polycystic kidney disease, the clinical manifestations are present at birth. Third, in adult polycystic kidney disease, the cysts are spherical and external surface of the kidney is lobulated. Whereas in infantile polycystic kidney disease, the cysts are cylindrical and external surface of the kidney is smooth. In adult polycystic kidney disease, the extrarenal involvement include cyst in the liver in 40% of the cases. Cyst may also be present in the spleen, pancreas and lungs. Third, there may be intracranial berry aneurysm. And fourth, mitral valve prolapse may be present in some patients of adult polycystic kidney disease, whereas in infantile polycystic kidney disease, the extrarenal involvement is hepatic fibrosis. So these were the differences between adult polycystic kidney disease and infantile polycystic kidney disease. Now the third type of cystic disease of kidney is medullary sponge kidney. So, medullary sponge kidney is a congenital disease of the kidney which is characterized by cystic dilatation or ectasia of the papillary duct in the medulla. It is usually asymptomatic unless complicated by urinary tract infection, nephrolithiasis, or hematuria. Patients with medullary sponge kidney are at increased risk for development of kidney stones, urinary tract infections. It is typically incidental finding which is detected radiologically during examination of adult for stones. Morphological feature of medullary sponge kidney. So grossly, the kidneys may be enlarged, normal or shrunken in size. The cut section shows several small cystically dilated papillary ducts which may contain calculi. The picture shows cut section of medullary sponge kidney on right side. So this is cut section of medullary sponge kidney on right side, and on left side this is normal kidney. This is normal kidney. Now this is the pyramid. These are the pyramid of the kidney located in medulla. These pyramids have many small cysts. You can see here, these pyramids have many small cysts. These are the cysts which are present in the pyramid. It is formed due to dilatation of papillary collecting duct. These cysts are small and numerous, and it leads to poor drainage of urine, making it easier for stones to form. So in medullary sponge kidney, there is increased risk for development of renal stone and UTI, that is urinary tract infection. Now the fourth type of cystic disease of kidney is nephronophthisis and adult onset medullary cystic kidney disease. This group of renal cystic disease is characterized by presence of cyst in the medulla, usually concentrated at the cortico-medullary junction. Some investigators view medullary cystic kidney disease and nephronophthisis as part of the same disease complex. Medullary cystic kidney disease is an autosomal dominant adult onset kidney disease. Grossly, the kidneys are normal to shrunken and maintain the reniform appearance. Microscopically, the kidney shows focal tubular atrophy and dilatation with cyst formation. The cysts are typically at the cortico-medullary junction. And are lined by columnar, transitional or metaplastic squamous epithelium. So these cysts in medullary cystic kidney disease are at the cortico-medullary junction. Now, second is nephronophthisis. This is an autosomal recessive disease of childhood. Whereas we have seen that medullary cystic disease is an autosomal dominant adult onset kidney disease, whereas nephronophthisis is an autosomal recessive disease of children or childhood. In nephronophthisis, the gross and microscopic appearance is same as medullary cystic kidney disease. Nephronophthisis is also called juvenile nephronophthisis or uremic sponge kidney. So these are the other name, that is uremic sponge kidney or juvenile nephronophthisis, because this is common in childhood. It is the most common cause of end-stage renal disease in children and adolescents. Now the fifth type of cystic disease of kidney is simple renal cyst. The simple renal cysts are asymptomatic, incidental finding on abdominal imaging, and these are rarely responsible for symptoms. However, symptoms may appear from rupture, hemorrhage, or infections. This is rare in infants and children. This is generally seen in adults above 50 years of age, and this is an acquired lesion. The simple cyst is commonly located in cortex. It varies in size from few millimeters to 10 centimeters in diameter. The cyst contain clear, straw-colored fluid. On microscopy, the single renal cyst is lined by single layer of flattened or cuboidal epithelium. So these cysts are lined by flattened epithelium or cuboidal epithelium. The picture shows simple renal cyst which is located in cortex. This is the simple renal cyst and this is located in the cortex. It contains straw-colored fluid and is usually asymptomatic and is detected incidentally on abdominal imaging.